Hello, everybody, and welcome to Community Conversations here at Atlantic Health System. My name is Luke Margolis. I'm the Corporate Communications Director for Atlantic Health, and today we're breaking a little bit of new ground here on Community Conversations. We have 3 guests joining me on set today, so I'm super excited about that. It means the show is going to be 3 times as good. So hopefully everybody subscribes on our YouTube channel, where this will live after we complete here on Facebook Live. But first, why don't I do a little introduction and let you know who the real stars of the show are today. Seated directly to my left is Dr. Yaron Moshel. He is a neurosurgeon and the co-director of the Glasser Brain Tumor Center at Atlantic Health System. Doctor, good to see you.
Thank you for having us.
And to his left is Dr. Nicholas Mitras. He is a neuro-oncologist with Atlantic Health System's Overlook Medical Center. Doctor, good to see you.
Good to see you as well. Thank you for having me.
And certainly not least, maybe last in our introduction around the horn here is Dr. Joanna Emilo. She is the Director of Radiation Oncology at Atlantic Health System's Overlook Medical Center. Doctor, thank you for joining us today.
Thanks for having me.
All right, so that is the panel of experts we have here. Here is how the program will work. We will be live here on Facebook for the duration of this conversation, but in case the feed drops out or you have to answer the phone or bail out for whatever reason, the entire thing will live on our Facebook page afterwards. Like I said, it's also on YouTube. You can also find all of our community conversations on our website, atlantichealth.org, where you can also find all kinds of other information about the various services we provide here at Atlantic Health System, including further detail on the subject we are here to talk about today. As you saw in the title of the program, it was called Treating Brain Tumors, and the 3 doctors next to me are going to tell you all about how we do that here at Atlantic Health System. So thanks so much for joining, and away we go. Dr. Moshel, I'd love to start with you, if you don't mind. The way in which these services are provided, the facility we provide them in, the Brain Tumor Center, I've heard a phrase mentioned multiple times, both when we've talked about it and I've heard others talk about it, and I'm hoping you can describe what it is and the value it brings, and that is multidisciplinary. For our audience who may hear that in great Scrabble word, right, a lot of points, but what does it actually mean? What's the value of that?
So the word multidisciplinary means incorporating multiple disciplines, right, at face value. But I think we're taking it to a whole other level. I think the way this started was medicine, and especially brain tumor care, was very fragmented, right? So people would come and see me as the neurosurgeon, and I would do the operation, look at their MRIs, and then refer them to these guys, right, to Dr. Amolo and to Dr. Mitras. And then the patient would have to go there. Maybe they got there, you never know. Sure. Was that appointment scheduled? Did they miss it?
Life happens, yeah.
There's a lot going on, and people are sick, and the families are struggling with this stuff. So we took it upon ourselves to say, let's consolidate all this and bring it all under one roof, which allows us to say, we're just gonna come to you. So take that headache away from the patient. So that was the initial, that's how it started. Let's make life easier for our patients. But then it sort of progressively improved, and I think we're right now kind of doing a Brain Tumor Center version 3, right? So we're always improving. So in the beginning, it was all under one roof. But now really what's happening is a lot of patients will get their cases reviewed by us collectively at a tumor board. So we, at the beginning of the day, have reviewed everyone's cases with an entire team of neuroradiologists, neuropathologists, medical
Like literally
oncologists.
around a table?
Yeah, in a big conference room. We actually review their slides and their MRIs and everything. And then we go spend the rest of that day seeing the patients together with their families collectively as a group. So we went from serial appointment scheduling to actually seeing people together. And it's fun. I think sometimes we'll even debate and argue in front of our patients.
Maybe today, you never know, it could happen.
But I think that adds value, because sometimes these decisions are hard, right? They're not easy decisions. There's more than one angle. You need to cater the decision to the patient, and so we want to hear all the voices. We want the patients to participate in that decision making, and so the idea of multidisciplinary is we're bringing all this together. We're working together. And I think we also help each other. We bounce ideas off each other.
I think the best part is that I'm learning from you and learning from, instead of coming at it just from a radiation oncologist perspective, I'm getting the surgeon's perspective, the neuro-oncologist, the radiologist can help me, which is huge when, I use the radiology to target my treatment. And so then I have someone to say, well, you know what, I would include this area. This looks like a high-risk spot too. So I think we're learning from each other. We learn, a little bit about each other. Instead of operating in silos, a little bit about what everybody's perspective is, and it gives the patient a better a better treatment, hopefully a better outcome, and allows us actually to truncate this time to starting treatment too. Things happen a lot faster when we don't spend a week waiting in between appointments, and we just kind of do everything all at once in day one, and make plans to start on the, on this day, and we just keep things kind of moving forward.
What's the value of that, Dr. Mitchers? Time. I mean, the ability to move quickly, I would imagine, when we're talking about brain tumors is essential maybe, but certainly important.
Absolutely. I mean, once you've been diagnosed with a brain tumor, you want to know next steps. And getting to those next steps is really important, because what I've found is that the waiting is one of the most difficult parts. And so by having this multidisciplinary approach, the first time after you've had surgery, the first time that Dr. Emelo, myself, Dr. Moschel for the postoperative visit, that we walk into the room, prior to that, we have looked at your MRIs, we've looked at your brain tissue and actually seen what the pictures of your tissue look like. We've talked about what's not only the next step, but the step after that, and maybe even the step after that, depending on if it's a straight line. And we know a little bit more about you, because when we're having this discussion, it's not just a medical discussion. We might talk a little bit about something interesting about the person that we're about to see. Maybe they have an interesting hobby or an interesting job. And so when we're first walking into the room, we know a lot more about you, and I think that helps to get things moving and to develop that relationship. I think a lot of patients would say that they're really comfortable with those initial visits, and they feel like they're being really well taken care of.
And the treatment's tailored specifically to them.
Okay, right. So there's a sense of feeling like this is not checklist type medicine.
This is about me specifically.
Yeah, I think it's really important, because like for example, we'll see patients who, it's really important for them to keep working, and they work in New York City. They're commuters. They have a certain train schedule they got to hit. So, like Dr. Emelo will work very hard to make sure, okay, you come here, you do your radiation at this time. We'll get you at on that train, so you can tell your boss at work you'll be in at this time every day.
Making that
making that little makes a big difference. And then I think what Dr. Emelo said earlier is important. Like I'm already a neurosurgeon, but in this process, I've become a little bit of a radiation oncologist, right?
Yeah.
And a little bit of a neuro-oncologist, and vice versa. And I think we all now think a little bit like each other, and that actually goes a long way. So in the middle of surgery, sometimes I'll know, like, hey, Dr. Emelo would treat that part with CyberKnife. I can hear her voice, and it makes
I'm
it.
pretty sure he hears my voice all the time.
But to me, that's more than collaborative. That's iterative learning. That's taking from each other, which I think harkens to the points you're making about it. So I want to, just as a reminder for everybody who's watching, the questions are not all mine to ask. If you hear something that you want a little more information around, or if you have something about our subject matter today that you've been meaning to ask and just want some information, here's your chance. Put it in the chat thread. They'll send it over to me, and I'll get to as many as we can within what we've got. A number of questions were asked in advance of the session by folks who submitted them through email, so we're going to try to maybe get to those first, but we're going to do as many as we can in the time allotted. Before we do that, though, I want to take a little bit of a step back, because I think for some folks who saw the subject matter treating brain tumors, is it treating brain cancer? Are all tumors cancerous? I think if we can do a little bit of a step back, I think that might be valuable for our audience. So for whoever wants to kind of start with a little bit of a 101 here, are we talking exclusively about brain cancer, or is it more than just that? Is that too broad of a catch-all term for what we're talking about here? Whoever wants to.
I think that a lot of what we work on is, we may not even know what the diagnosis is as we go in. For some patients, we're just following some kind of abnormality in the brain and seeing what that does over time. So we may even be following pre-diagnosis. But I think to just make a broad scope about what we do is not really fair, because every single tumor has maybe different grades that we could talk about. So for those who may have friends or relatives that have cancer elsewhere in the body, we usually use the term stage, like to say that a stage 4 lung cancer has widely metastasized or widely moved throughout the body. But in brain tumors, by and large, they don't leave the central nervous system. And so we had to come up with new terms to use. So we don't use stage, we use grade. And for each one of the tumors that we help to treat, there may be different grades. So, one that is commonly in the news and one that a lot of people have is a meningioma. A one meningioma may not be the same as another because there's 3 different grades of meningioma, and the higher the grade goes, the more aggressive that tumor can get. So by and large, a lot of people are going to have a grade 1 meningioma, but it's important to go to specialists that specialize in what we do so that we can help to distinguish, this one needs to be treated like this and this one needs to be treated like that. So
like meningiomas are a common example of a tumor that is often found incidentally, and our advice is often do nothing. We just watch it, right? Because they're typically benign tumors,
right?
And when they're found small, and if we decide that it needs to be treated, if they're of a certain size, it often can be treated with CyberKnife. It's not just always surgery.
Yeah.
Right?
I think the tough concept with brain tumors is when we talk about benign or malignant, you've heard me use this analogy before, and I'm sure you're tired of hearing it, but the brain is all about real estate. It's location, 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 right? And so some of these tumors can be benign, but they can be in a location where they're creating a problem just based on the geography and what they're impinging on. And so, for that person, that's a fairly malignant process, even though it's really, benign pathology. So it's a tough concept, I think, in brain tumors, and it's not so easy to say, oh, this is benign, don't worry about it, and that's malignant and worry more. It really depends on where and what we're dealing with and what the capacity for change over time is, and that's kind of what you were getting into with a grade and whatnot.
I think that really speaks to the personalized approach that we have to bring to each one of our patients, is that you are not just the next patient in line to be seen with diagnosis X. We have to think about the location, the size, the age of the person, other medications that they're on, if we need to try chemotherapies. So it's a very tailored personal approach for each patient.
Which may also be the same for the question I'm about to ask you, but it's sort of, we got it in a couple of different formats ahead of our session today, but essentially it's how do patients come into your care? What are the symptoms or signs or reasons upon which a patient would find themselves in the multidisciplinary center?
People show up for all sorts of reasons. I think today what's happening is there are MRI facilities, almost like in every town in New Jersey has an MRI center, right? So people are getting MRIs more frequently, so we're finding a lot more brain tumors that are found incidentally. Those benign meningiomas, or even low-grade tumors that can be, it's a whole different challenge of how you deal with them, but they're types of brain tumors that we kind of consider like a precancerous kind of condition that often present without symptoms, and they're found incidentally. So that's one way. Another way is people they develop neurologic problems. Typically with a brain tumor, it's not like a stroke where you have a sudden onset problem, like where it's an abrupt beginning. It's typically more of a lingering thing. Unfortunately, a lot of people develop problems, and in our busy lives, people often chalk it up to it's just old age type of thing, and kind of ignore symptoms.
Yeah, slowing down a little bit, or
right,
whatever it makes.
Yeah, exactly, and people get symptoms. Some of those symptoms can be very vague, like some cognitive fogginess, some memory loss, occasional difficulties. I just saw someone recently who thought nothing of it, but he just couldn't come up with a word. He can read the word. He reads to his kids. He can read the word. He sees the word. When he has to say it, he can't get it out. But it's kind of gone on slowly for weeks and weeks and weeks. I think other signs are some kind of weakness on one side of the body. Okay. Sometimes, Nick, I don't know if you want to chime in, like people can get seizures, right? That's another presentation.
That can be, and seizures aren't always what we see on TV where someone falls on the ground and starts shaking. Seizures can be just a passive, odd sensation that they feel. Depending on where it comes from in the brain, seizures can have different symptoms. Even an intense feeling of deja vu that is recurrent, and then you feel exhausted afterwards, that's actually another kind of presentation of seizure. I think in the brain and in the nervous system in general, it's not what you have, but where you have it that gives you your symptoms. And so one of the big concerns that I've heard people say is, I've been having headaches. And is my headache a brain tumor? Yep. And if you think about the millions of people that see their primary care doctors or a neurologist with headaches every year that are just migraines or a different kind of headache, and then the far less amount of people that are diagnosed with brain tumors, we have to start thinking about what makes that headache a little bit different. So I like to think of it as headache and. I have a headache and my arm is weak, or I have a headache and I've been having a little bit more confusion than I was having before. Or my headaches are only happening in the morning time, and they're much more intense than anything else that I've been experiencing before. And so the presenting symptoms for a brain tumor are not always the same. I think a good rule of thumb is if you feel like you've been having something new that you weren't having before and it's of concern, have it checked out by your primary care doctor.
Which is a great point, a great opportunity for me to make this point too. We're going to be taking some questions from our audience shortly. I want to just make sure that everybody understands. Obviously, we don't diagnose through Facebook. That is not a great rule of thumb for folks in what we do in our line of work to do. So please note that we'll try to answer some specific questions as they come up, but certainly any direct questions that you may have about your personal situation are best directed to your physician, and then obviously making a decision with that physician as to how to move forward and what specialists to consult as need be. So hopefully everybody understands that as we enter into that phase of it. But before we do though, radiation oncology, neuro-oncologist, neurosurgery. There's three distinct verticals, if you want to call them that we're talking about here. Can we just touch on a little bit of the differences between the three and explain, just so for our audience can follow along, how your roles are incorporated into each of those? And Dr. Amelo, if we want to start with radiation oncology, why don't we start with you?
So radiation is always a tough thing to explain, but what we're trying to do, or what I do, is focus high energy at the problem, and we use imaging in order to help guide us to do that. So CAT scans, MRIs, we outline the area that looks abnormal on imaging. Sometimes I use these two to help me out with that. And then myself, I have a whole team of physicists. We come up with the appropriate treatment plan that helps us to kind of paint the radiation treatment onto where it needs to go. And again, high dose X-ray where you don't see anything, you don't feel anything, it doesn't hurt. I think that sometimes can be slightly disconcerting to patients. They lay there and they think that's it. Yeah. It's pretty anticlimactic. But here we are trying to really kind of sculpt the radiation dose around the problem area while we protect all the normal tissue around it.
Awesome.
But I think something else that you mentioned though is she has, you talked about your physics team. I think we represent specialties, but behind each of us, she happens to have a particularly wonderful team of physicists and radiation technologists.
I have about 20 people that prop me up every day that do all the hard work.
Yes. There's a lot of work.
Shout out to them.
Yeah.
Sure. Dr. Mitras, neuro-oncology. Can you explain just for our audience? I mean, look, I'm sure we could talk for a half an hour just on that, right? Neuro-oncology, go, right? But for as best we can, let's see if we can encapsulate a little bit of the work that happens there.
I think a neuro-oncologist is the unicorn of cancer treatment. There's only 200 to 300 of us in the country. As in terms of a board-certified neuro-oncologist.
And only 2 in the state of New Jersey.
And only 2 in the state of New Jersey, and they're both at the Glasser Brain Tumor Center. So 2 under one roof. We have a different kind of training. So we start as a general neurologist, seeing strokes, seizures, headaches, MS, conditions like that. And then we do further specialization in either primary brain tumors, meaning a brain tumor that began in the brain, or the spine, and then brain and spine metastases. And so cancers elsewhere in the body that have now gone into the central nervous system. But then also the neurological complications of cancer. So with that kind of background, Dr. Aiken, the other neuro-oncologist here with us, and myself, we can not only help to treat the underlying brain tumor we're more of the chemotherapy side of things, but also as treatment goes on, there may be other complications. Like for example, we've been talking about seizures. So instead of having to go somewhere else to get your seizures treated, somewhere else to get your headaches treated, and then somewhere else to get the actual tumor treated, you just have your treatment under one roof. And we can manage those things because we have that training background in all of them.
Excellent. And Dr. Michelle, neurosurgery, the surgery part of it, I think people conceptually probably have their arms around, but can we talk a little bit about the neurosurgeon's role in our process?
Well, so I do brain tumor surgery, and brain tumor surgery is a subsection of neurosurgery, right? We focus on the brain, and there's a lot behind that. Like we can spend a whole day, like you said earlier, talking about it. I think the brain obviously is a very complicated organ, and there's so much that we do, whether it's awake surgery sometimes to map out speech function in patients. We use all sorts of technological adjuncts in the operating room. Like lately, we'll talk about it later, I'm sure, we've been using fluorescent imaging in the brain. We have these GPS type navigation devices that help us navigate around the brain. But neurosurgery is basically the art of doing surgery to try to remove a brain tumor in this case, and we try to remove as much as we can, but we want to remove it safely without hurting patients, and making sure that every year it's in an iterative process. We're doing it less and less invasively, and people hopefully are going home sooner and doing better. That's the goal. Yeah.
A couple of things you touched on there that are reflective of some questions we've got from our audience. Pamela asks about how technology has changed what you do. You were just hinting at the shorter recovery times and better outcomes. So let's start there. How has the advancements we've seen in your respective fields advanced the way you're able to provide care?
In radiation, it's huge. We're very computer reliant and dependent, and in terms of the technology with the machines just able to deliver the radiation in a more focused, more pinpoint manner, really carve out the normal things that are surrounding our brain tumors so that we can protect them from the exposure. It allows us to give higher doses so patients have better control of their disease, again, live longer and live healthier with less toxicity or long-term effects from the exposure. So in radiation, it's been tremendous. When I started my training 16 years ago, we were doing a lot of whole brain radiation, a lot of this kind of broad field of treatment, and we've really moved so far away from that, and in what's really not a long period of time. And patients just are overall doing so much better because of it. So.
Yeah, I think there's a lot of overlap in the technology that Dr. Amolo uses when she uses the CyberKnife machine. I mean, it's basically answering at least that component of the technology is answering the same question, which is, I'm looking at an MRI, and there's a problem there. There's a tumor. How do we get to it in surgery, or how do we target it with radiation? Yeah. And it gets to a very basic problem of, here's this MRI. Well, how do I convert those coordinates on the MRI to real 3D life coordinates in your head, so that this robotic arm can deliver radiation to that spot,
to that one spot,
in a way that we're confident that we actually believe it. And similarly, how do I do surgery and open up a person's head and make sure I'm right over that spot, that I'm not in the wrong spot? It's a simple question, but it's a hard answer.
Well, you wouldn't want me to answer it that way. You mentioned awake brain surgery, which is another question we've got about. Is that something we offer at our facility?
Oh, yeah.
And what is it? I mean, is it literally what it sounds like, brain surgery while the patient is awake?
Yeah, we do surgery while the patient's awake. It's kind of fun. Then the patients, I think some patients go in very scared, but they actually come out having had some fun.
You've had some patients sing to you while you're operating.
Yeah, we have patients sing to us.
Deliberately, or is that?
No, yeah. And then we tell patients, listen, I don't give them food, but I'll let them sip on water, have a snack, or sip some water during the surgery. But you don't feel the brain, so we can numb up the skin and kind of knock you out a little bit while we do the bone work on opening the skull, and actually expose the brain with no pain and with the person wide awake. And sometimes it's really important, especially when it comes to speech function, right? I don't have a way to test someone's speech while they're asleep. And so I can remove a tumor in the speech centers, but if you're asleep, I can't guarantee that your speech is going to be okay. The only way I can guarantee that is by testing your speech during the surgery, making sure it's okay. Wow. And again, just like we talked about earlier, behind that there's a tremendous team. So we have a team of epilepsy doctors that are there monitoring the brain activity during the surgery. We have a technician, JP, who's there under the drapes with the patient, talking and doing a lot of the testing and the speech and language testing. So a lot goes on behind the scenes, but it's actually interesting. Patients who stay awake in surgery, they tend to actually go home sooner, having avoided all the medications and the issues that anesthesia can cause.
Wow. I want to do a couple of individual questions from some of our folks, and then I want to pick up on something you just were talking about. Let's start first with Betty. Betty has a question regarding a meningioma. I don't know if I want to pronounce that right, meningioma. Her husband has a small meningioma. Should he be having it checked, and how frequently should that be happening? So for Betty, for any of our doctors who
Nick, do you want to take that on?
So I think a good rule of thumb is to watch meningiomas every 1 year, unless any new or worsening symptoms are developing. And we kind of track the progress of it over time. Not all meningiomas are going to grow. Some of them are going to stay very stable or grow so subtly that it's very difficult to pick up on something like that. And so it's more of just checking to make sure annually that there's no new symptoms, and that's where the neurological exam can come in handy to try to pick up on any symptoms that just may be missed as the person goes throughout their day-to-day life. And then just to watch and see if it's gotten any larger. If there is some kind of growth, that patient may become a discussion at our tumor board. And so we may talk about, is this something that can just be watched for a longer time? Is this something that we want to do some cyberknife radiation on? Is this something that warrants surgery? So it's an ongoing conversation with each patient.
Marilyn had a similar question about how frequently should be checked for growth, so hopefully, Marilyn, that answered your question as well. Dr. Emelo, David wants to know, how do you know when you've maxed out on the acceptable limit of radiation with cyberknife to the brain as part of a post-surgical treatment?
That's a complicated question, only because all of our tissues have a lifetime limit in terms of how much radiation they can safely see before we cross the threshold into increasing risk for damage from the radiation. But there is some capacity for recovery, so some people over time do have some recovery from the radiation exposure. That might give us a little bit more room to give more treatment if need be.
So the answer really is it depends, David.
Depends, yeah. Depends on how much treatment's been given and how much, and where we need to come back to and how close it is.
And if it's the same spot also, right?
Yeah.
Like if it's a new spot versus the same spot.
And I think kind of getting back to how the field has changed and how the way we deliver treatment has changed, I think we're learning what's safe to do. There were things that we previously thought were not safe, was too much radiation, was too fast to give a treatment, and now with more time and experience, we realize, well, you know what, maybe it's not as scary or as unsafe as we thought. So I think we're learning to push the limits, and the technology improving is helping us to do that. So it's kind of a moving target.
Yeah, there are definitely things that we're doing now, I think in radiation, that we were scared to do even 5 years ago.
Yeah.
Absolutely. Because of the advancements we've had.
Yeah, the data comes out and things, it's really a very fluid field right now.
We talked a little bit about the awake brain surgery and the way patients respond emotionally to having that type of procedure. But before the treatment begins, I would imagine when you tell a patient that they have a brain tumor, there is an awful lot of, we'll say, concern on their part, I'm sure. What types of support do we offer patients? How do we work with patients on what may be an unsettling diagnosis when they first receive it? What are the types of support services we can in place for patients?
So we're just 3 members of a broader team, right? And so we have another neurosurgeon, we have another radiation oncologist, and another neuro-oncologist. But in addition to that set of physicians, we also have Dr. Barrow, who's a retired neurosurgeon, also treated a lot of brain tumors, but is also a deacon at the church. So he's kind of become our family advocate. I think that's what we call him.
That's a powerful thing.
And he's amazing. He'll visit with families, speak to families, get to know them. He's very skilled and also comes to it with a very broad knowledge base. So he's been great. And then in addition to that, we also have Janet, who is our navigator and social worker for the Brain Tumor Center, and she interfaces with every family that we treat. And she's been great. She's been great as sort of being the coach, the family coach. She's also been great at coordinating other social services, right? So some people need more in-depth social work or need more help, or they need to get referred to the child life program because they have children who are having a hard time coping with the diagnosis. So she will help coordinate a lot of that care.
Excellent.
Transportation issues,
Right,
insurance problems.
A lot of times it's the mundane issues, right?
Yeah.
It's
not the super scientific.
It's the day-to-day
Yeah.
logistics of how do I get to therapy? How do I pay for therapy? How do I explain this to my children? How do I keep living throughout the course of my treatment? So.
And I think another unique thing that we have that patients have found really beneficial is the support group that we have.
Right.
There's not always enough time in a visit to talk about everything. And so there's some questions that come up often that we're able to make some talks about. And I just recently gave a talk at our support group about supplements because it's something that comes up a lot.
Like nutritional supplements?
Right, exactly. Like, what can I take? What's safe? Should I be taking this? What should I look out for? And it's not something that you can always fit into the time that you have with the patient. Because there's a lot of things that we need to cover over the course of our visit. And so the support group gives a chance for us to kind of flesh out some of those other things that are really important, we just may not have time for in a normal visit. But also, I think all of us recognize that we can't truly feel what the person's going through having not gone through it ourselves. And there's something much more meaningful about sitting across the table from someone who is really going through what you're going through. And so when we have that support group, it's more of like a potluck so that our patients can sit together and talk. Are you having this symptom? Oh yeah, me too. Well, I found that this works for me. Oh, I'll try that. It makes a lot more of a difference to have that relatability.
Empowering.
Yeah, absolutely.
We are running way low on time, so I just want to, maybe we can even lightning round these a little bit. We've got a couple of ones to do here. Teresa has one that I'm going to try to read without totally screwing up. So Teresa, bear with me. Teresa wants to know, is a 0.6 centimeter anterior right front dural-based calcification that could be a small calcified meningioma be a concern and need follow-up visits if asymptomatic? I'm exhausted after reading that. Hopefully I got it all right. Is there I don't know the answer, Teresa. Luckily these three may. Is there an answer we can provide, or is this best left discussed with a physician, with her physician, or what do you think?
I think the more we do images on people, the more we find these things that we're not quite sure what to do with, because it wasn't the original reason why we got the imaging study in the first place. Mm-hmm. Maybe it's somebody with headaches and we got an MRI and it doesn't really explain their headaches, but now it's something that we know is there. And we see a lot of those come across our clinic. And I think that it's a good idea to have some kind of follow-up with that, mm-hmm. to have some interval additional imaging to make sure that that thing isn't changing over time, but that if you're going to continue to follow something, you could probably stretch out how often you need to see it over time. And if it's asymptomatic, then that certainly goes to that it's not likely to be something aggressive.
Got it. Mark had a number of questions, so I'm going to do a little editorial prerogative here and just pick one. Mark wants to know, having to do with transport mechanism. Essentially, I'll just read it right off there. When experimenting with direct chemo injections to the brain, why is a transport mechanism not considered to help get the treatment where it's needed in the brain rather than pooling in one spot? So this notion, we were talking a little bit about radiation being targeted to one area. Mm-hmm. This would be about medication to one specific area. Is there an answer we can provide to Mark there?
Well, we've always struggled with getting drug delivery, and Nick can speak more about this, drug delivery into the brain, right? People have tried injecting things directly in the brain. The problem is that the body, as a protective mechanism from Mother Nature, created this thing called the blood-brain barrier. So all the blood vessels in the brain have this sheath around them, so only very specific things can cross across the blood-brain barrier and diffuse into the interstitium, like the space around the cells within the brain. And that's great because it protects the brain from all these toxins that float around the body, but that stinks for neuro-oncologists because it also blocks drugs from getting in there.
Yeah, we want to get something in there, it makes it a lot harder.
Exactly. So I think there's been some very interesting ideas in recent history through like ultrasound to try to modify and open up the blood-brain barrier, and using different molecules that may be able to make it through, whereas others can't. So I think that we're getting smarter about understanding this barrier a little bit better, and that with that understanding hopefully comes new means of breaking through that and getting the treatment where it needs to go more efficiently.
Excellent. Well, I'll tell you what, I feel smarter having just had this conversation with our three doctors today. I want to thank each of you for joining us for this conversation. We are out of time, unfortunately. I think we all said we could go a half an hour on every one of these things, so we tried to do it all in a half an hour cumulatively, which is quite tough. So I appreciate all three of you for joining us.
Thanks.
Thank you for having us.
All right, once again, it's Dr. Yaron Moshel. He is the neurosurgeon and the co-director of the Brain Tumor Center for Atlantic Health System. To his left is Dr. Nicholas Mitras. He is a neuro-oncologist at Atlantic Health System's Overlook Medical Center. And to his left is Dr. Joanna Emelo. She is the director of radiation oncology at Overlook Medical Center. Again, thank you all so much, and thank you for joining us on Community Conversations. We appreciate all of your questions. If you missed anything, atlantichealth.org, where you can find them all there. Plus, lots more information on the amazing work they do. So thank you so much for joining us, and we'll see you next time.